Before I go on, thank you Tanuj and thank you AIOS for this opportunity. There are no financial disclosures. Well, the outline of this talk would be Gonioscopy, which is an invaluable part of diagnostic tools available. We'd go through a brief outline about techniques and what to look for, a couple of clinical scenarios, and maybe validate the clinical impressions with the UVM if you have time at the end. So, visualization of the angle in vivo was not described until Trantas in 1907 indented the limbus of a keratoglobus eye, bringing the angle structures directly into view. Now, this distortion of the globe is obviously uncomfortable for the patient and provides only a limited clarity. Trantas in 1918 coined the term gonioscopy from the Greek gonia, which means angle, and skopin, which means seen, to refer to the examination. Why is it important? It's because direct observation is not possible with direct observation of the angle is not possible. The scleral tissue projects anterior to the angle and the curvature of the cornea creates an internal reflection. What the goniolens does, in effect, is permits visualization of the angle by eliminating the cornea as a refracting surface by placing a concave surface against the cornea. So the types that we all know of are the direct and indirect. It only means that the light rays are refracted directly to a cornea contact lens interface. You require a handheld slit lamp preferably, but you can also do it with the tilt of a microscope in the OT for magnification and illumination, and the Queppe lens is the prototype. But what is clinically used day in and day out is indirect gonioscopy, which uses the principle of total internal reflection, and the light rays are reflected by a mirror in the gonioprism to the observer and focused with a slit lamp by a microscope. But because it's a mirror, the angles that are seen are opposite to what you're viewing. So the most commonly used, we'll be talking of indirect gonioscopy, the most commonly used ones are the Goldmann 3 mirror and the Zeiss 4 mirror. You get an direct virtual image of the fundus as well as an indirect view of the angle. But a Zeiss 4 mirror for glaucoma or any 4 mirror for a glaucoma practice is more useful. One, you get a view of all 4 angles at the same time. Secondly, the curvature is less than that of the cornea, so you can indent it and look out for whether the occlusion is synechial or not. So which goniolens to use? There's not much to choose as long as you use one. The advantage of a 3 mirror is that it will be good for a multi-speciality practice where you can see peripheral retina through some mirrors. The disadvantage is you'd have to rotate it to look at all 4 angles. But if you're doing primarily glaucoma practice, then as I said, the Zeiss 4 mirror type is very, very useful because the diameter permits indentation gonioscopy. So just a quick word about the slit lamp preparation, the lens preparation and the patient preparation. So you need low magnification and low illumination to start with. A parallelopiped is useful, 2 mm width and maximum height. To see the angle in its entirety, it's nice to orient the beam parallel to the axis of the mirror, vertical for the superior, inferior and horizontal for nasal and temporal. But be careful not to impinge the beam of light on the pupil and prevent artifactual angle opening due to pupillary constriction. Between patients, hydrogen peroxide ideally, and it should be allowed to air dry. So a practical thing what we use is have it in a petri dish just next to our slit lamps, and it's dipped in that and air dried before putting in. So between patients, that's a useful, quick way of cleaning it. But at the end of the day, it's always cleaned with soap and water and rinsed with saline and allowed to dry. Do not use absolute alcohol since it's been found to damage the lens. Usually, the Goldmann requires installation of some fluid, 2% HPMC does just fine. You need to fill the concave surface if it's a Goldmann, but the indentation ones don't really require it. The tear film is good enough and there's no coupling fluid necessary. So it's important to explain to the patient in layman's terms. I've put an applanation tonometry picture here because the way the patient is seated on the slit lamp is pretty much the same. The forehead against the forehead rest and align the lateral canthus with the alignment of the slit lamp. So you need to instill the anesthetic and always try to do the tonometry first, because if you've done a gonioscopy and you've already pressed upon the eye inadvertently, you might have fallacious rise or even lowering of pressure at times. This little girl is just 3 years old, and just to say that if you're really, really friends with your patient, anybody will let you gonioscope. She's an exception, of course, but it is possible. So when a resident comes and says, gonioscopy not possible in this patient, I'm not really impressed with that. Because if you talk to them and you are gentle with your technique, most patients would cooperate. So you need to grasp the goniolens with a thumb and forefinger. Have the patient look down, firmly grasp the upper lid with a thumb, rest the goniolens on the lower lid margin, tilt the lens up to meet the cornea by asking the patient to look straight ahead to meet the goniolens, and then gently place the goniolens on the cornea. It's important not to press upon it because then you might artifactually open and occlude